Hi everyone, and welcome to the February webinar for Choosing Wisely. So my name is Jessica Shepherd. I'm the Choosing Wisely program lead, and I'd like to start by acknowledging the traditional owners of the land on which we meet today, and I'd like to pay my respects to elders past, present and emerging. And it's my pleasure to welcome today Dr. Anna Peach and Dr. Lana Vestakis from the Sunshine Coast Hospital, who will be presenting their perioperative pathology project. So there'll be an opportunity after the presentation to ask any questions. So please do submit those questions via the Q&A function at the bottom, and we'll address those after the presentation. And I'll pass over to you now, Lana. Thank you.
Thank you very much, Jessica. And on behalf of myself and Anna, we'd like to thank you for Choosing Wisely for inviting us today. We're very excited to share our results with yourselves. So, starting, why are we here today? Well, as anaesthetists, we are constantly looking forward to improve patient outcomes. So we're involved in assessing patients in the preoperative anaesthetic evaluation unit, hereby known as PAU from now on today. So our PAU setup is a little bit unique to our hospital, and by that I mean that the blood tests that are done are protocols that have been devised by our surgical colleagues. They are then requested by nurses before we as anaesthetists have even seen the patient, and then we as anaesthetists check them and act upon them. And the problem with this approach really is there's no ownership of these blood tests. It's a bit of a blanket approach for everyone, regardless of their medical complexity. And sometimes the anaesthetist seeing the patient in clinic isn't even the same anaesthetist endorsing these blood results. We became acutely aware that there was an inordinate amount of blood tests being done here. Patients were having to drive over a large geographical area to get these done. We were spending a substantial amount of time checking these blood tests that we hadn't correctly ordered. But sometimes if you dug a little deeper, you'd find that stable patients that might have had a very similar panel of blood tests done very recently. So why are we repeating them? What grounds and evidence are all these particular blood tests done? Do they need to be repeated this often? Are we using these blood tests as just a screening tool, or would they actually change operative management or patient outcomes? And playing devil's advocate here, if we didn't do them, would there be patient harm? And so an idea was born to do a quality improvement cycle. What do we already know? Thank you, Choosing Wisely, for doing all this work for us beforehand. We already know that ordering routine pre-op tests is listed by Choosing Wisely and ANSCA, our unifying college, as one of the top 5 practices anaesthetists should avoid. And the National Institute of Clinical Excellence guidelines in England stress again and again that blood tests shouldn't be this just blanket approach everywhere, but more a tailored method. After doing some literature searches, we realized just how much this blanket approach is what's called a low-value healthcare, as in an intervention where evidence suggests that it confers little or no benefits. We're also very lucky that our Choosing Wisely faculty chair for our hospital is actually an anaesthetist in our own department, and he was very supportive of all our projects here. We had an inkling that there was a problem, but we needed to quantify it so we could understand the magnitude, and we also needed to pick up if there was going to be any adverse events if we didn't do these blood tests. So what did we do? We decided to do a retrospective 1-month audit of all elective surgical procedures done in February 2021. These were all patients that were seen in the PAU across all surgical subspecialties, and they range from minor to major operations. We looked at these patients and then compared all the blood tests that were done to evidence-based guidelines and the local protocols that we were following. After certain exclusions, such as patients on the enhanced recovery after surgery pathway and the anemia pathway, we were left with 527 operations that we wanted to have a look at what blood tests have been done on these patients. The first guideline, which are evidence-based, are called the statewide anesthesia and perioperative care clinical network guidelines. They're called SWAPNet, and they're based on the NICE guidelines from England, the National Institute of Clinical Excellence. They and I'd like you to very much to concentrate on the first statement, which is preoperative investigations should not be ordered routinely. And again, a big emphasis on tailoring the bloods to the patient's needs and the surgery they're undergoing. If you have a look at the green template, the green line where it says ASA 1, 2, and 3, ASA stands for the American Society of Anesthesiologists, who about 60 years ago devised a physical status classification. So for the non-anesthetists among us, ASA 1 is a normal, healthy patient. ASA 2 is one that has a mild systemic disease, such as, for example, very mild asthma. And ASA 3 is somebody with severe systemic disease, and so on and so forth. The classification carries on. But it's showing you how it's broken down into different physical status classification. And then it's also broken down into minor, moderate, and major. So there's a bit more of a targeted approach, not just a blanket approach to blood tests. The second guideline that we looked at is the departmental protocol guidelines. So in our hospital, our different surgeons have got different protocols for their bloods. If we're lucky, the department has one team protocol, such as, for example, orthopedics have got a team protocol. If we're not as lucky, there might be different protocols within the same department. So, for example, surgeon X, surgeon Y, surgeon Z having the same operation might have different blood test requests for the nurses to ask for. So it just meant that there was a lot more confusion around all these different blood tests that were required. And it kind of made us think, if there was 12 different types of protocols for the same type of operation, surely this cannot be evidence-based. And how often were these being reviewed? And again, if you have a look at this, there's no consideration for the patient comorbidities. Lastly, the last protocol that we looked at is the Sunshine Coast University Hospital guidelines that were devised in 2013. They're a bit of a hybrid of NICE guidelines, the Association of Anaesthetists UK and Ireland guidelines, and a bit of Johns Hopkins classification of surgery. There's a bit more of a breakdown about surgical severity. But unfortunately, for whatever reason, some nurses use them, some nurses didn't use these classifications. And so we were left with trying to figure out why certain blood tests were done for certain things. What was important wasn't just finding the results, but actually comparing them to all these different standards. So that's why we embarked on this quality improvement project. And these are our results in a nutshell. On the y-axis is compliance. And what I mean by compliance is how often do these blood tests match a particular protocol. The blue is the SWAPNet guidelines. The red is the departmental protocols, i.e. the surgical ones that were written. And the yellow is the Sunshine Coast University Hospital guidelines. On the x-axis are different surgical subspecialties, with the least compliant on the right-hand side and the most compliant on the left-hand side. Looking at these graphs, you can see that, for example, the pediatrics appear to be the most compliant, but you can probably understand why. They're very unlikely for children to have any blood tests done. But urology, on the other hand, have a less than 1 in 4, less than 70, urology, for example, less than one in 4 patients who are having blood tests done based on evidence-based guidelines. And that's where we wanted to target first. That's where we could really make a difference. Interestingly enough, we didn't seem to be even compliant with the surgical department protocols, the red lines. So we will look at that in more further detail. And looking at this graph with the Sunshine Coast University Hospital guidelines lens, the yellow one, it's a bit of a shame that they weren't being used more, as they were based on NICE guidelines from 2013. And as you can see, they correlate a lot more with the blue SWAPNet graphs. And imagine here, if over the last 7 to 8 years we've been using them, how much more money and how much workforce hours we could have saved. Think about how much waste in terms of blood bottles we could have saved as well. Over-ordering according to SWAPNet guidelines. If you look again, the dark blue is urology. Again, we have a smattering of blood tests that were over-ordered. But in total, over the past month in the PAU, there were 85 blood tests that were over-ordered, 114 chemistry bottles that were over-ordered, 65 clotting, and 88 group and holds. From a departmental protocol, which we found this very interesting, as we weren't expecting them not to follow their own protocols. Why was that? And essentially, we found when we asked the nurses, it was a matter of accessibility. There was quite a lot of disorganization amongst the computer, like the technology, the G drives. There was a lot of operations that hadn't been defined as minor, moderate, and major. So if a nurse hadn't been exposed to the theatre environment and couldn't quite figure out what kind of operation this was, there was no understanding of what blood tests were being done there. New surgical interns that added on blood testing on the blood forms, even then on the booking form, when they didn't need to be done. And overriding everything was this fear of surgical cancellations and delays. So more is more, and just in case attitude versus we don't need to have this done. So money talks. This is the bit at which hospital administration are interested in. What does this all cost us? All this over-ordering? And looking at this, particularly the graph on the right-hand side of your screen, we could show that our quality improvement project could have some big gains if we chose wisely and used NICE guidelines, net guidelines. In a 1-month period in our PAU unit, we could have saved over $9,000. But if you extrapolated that out to a 12-month period, that's just under $110,000. And this isn't an insignificant amount when you sit back and think about all the PAUs across Australia. And this figure is just the pure cost of processing these blood tests. But what about the cost of the workforce power in terms of time spent requesting all these unnecessary blood tests, printing the forms out, performing them, endorsing them? This amount is like literally the tip of the iceberg when you start thinking big. And bearing in mind, Australia in 2018-2019 spent $3 billion on blood tests.
So for anyone who's been involved in any sort of kind of healthcare change and quality projects, defining the problem usually isn't the difficult part. It's really the redesign and working out how we were going to actually make change. And so we're going to tell you a little bit about how we tackled it from here. So the first thing we did was we realised that actually engaging with people locally was important because, as Lana's already pointed out, it was actually a lack of ownership and probably, people working within silos that were really at the root of the problem. We met specifically with departments and we tried to target each department in regards to what they would, what the really critical thing for them was. So with urology, for example, we spoke about renal function, about the use of gentamicin and antibiotics. For general surgery, we specifically talked to them about the enhanced recovery after surgery protocol. And in orthopedics, we presented some data around group and holds for joint replacements and talked about who actually needs a group and hold done. We also talked to them and presented our audit and presented evidence around the repeatability of blood tests. And what we learned through kind of our engagement was interesting, that actually the important part for different departments was they had quite specific needs. And with anaesthetics, we were actually quite conservative and we were most concerned about patient safety. The nurses did not want delays and cancellations, and the surgeons just really wanted to operate, which isn't surprising. We also presented to them about the impact. So Lana's already discussed a little bit about the cost impacts, but even the bigger impacts, really looking at sustainability within our hospital as well. But importantly, we took them some ideas for solutions. So we took them some ideas and we actually worked together to find the solution. And I guess this is the thing that I think most people think about when we start talking is it really worth saving that money? So, as the orthopedic surgeon said to us, $100,000 over a year isn't that much money. So are we going to actually create patient harm by actually removing these blood tests? What we found over this entire month was really that there weren't very many outcomes that we could find from these blood tests. There were some notifications, there were some phone calls, and ultimately on bold on the bottom is that there was one iron infusion that was provided for a patient. But when we delved deeper, we worked out that that patient actually was missed by our anemia screening pathway. So really that intervention wouldn't have been part of this project anyway. And so then we moved on to implementation. And again, as we've mentioned, running a project like this with lots and lots of different people involved, we thought it was really important to break it down into small pieces. We thought that starting with a pilot project where we rolled it out with one department and provided lots of feedback and support meant that we could learn from that before we roll it out between other departments. From that, we learned about how best to support the nurses within our department, and things like being able to define surgical severity. So actually having lots and lots of different surgeries clearly defined was actually really helpful. We also created champions within that surgical area, which allowed us to be able to clarify issues, but also to be able to stay in contact whether or not there were any delays or cancellations of surgery, in which we didn't find any. And just to give you an example of the final table that we have come up with, this is an example of the one we use for urology. Again, it looks a lot like the SWOT neck guidelines in that it's got the surgical types down the left-hand side. It's got the ASA status across the top. And importantly, we've referenced it to show that actually it has come from evidence-based guidelines. And it's something also that we've set a date for review as well. So the last part of our cycle was around reevaluation and ongoing change. And this is something that I think we've both learned quite a lot about during this project. We learned that things that we sometimes could see from, say, an anaesthetic perspective didn't make sense to nurses. And even things like a blood test that we thought we'd be able to do point of care on arrival wasn't actually possible because of access to training. And so actually changing the way that we've done some of the blood tests has been really important. And remembering that with any change, so ongoing education and visibility has been really important, and that's something that we're still striving to do at the moment. I will tell you though that we have, after rolling this out in urology, been able to re-audit. And what we can show is that from our pre-intervention, our compliance with evidence-based protocols was about 23% of patients. And after our new protocol was released, we moved to 69%. Again, in some ways, it actually came to a bit of a shock, or to me anyway, that this number wasn't higher. But there are reasons why that number wasn't higher. And what's been important for us is to be able to go through each of those charts and learn from that and be able to actually make changes and re-release data. Our next plan is to roll it out across every department and be able to go back and re-audit. And as we've already mentioned, sort of ongoing review. We wanted to talk a little bit more about the impacts. And this is important to us because, as Lana has already mentioned, it's something that's actually quite hard to capture through audit. We've talked a little bit about the financial cost, but what we want to talk about is the workforce power. And this is something that's important because, as Lana mentioned, for the blood tests, we needed to print the form out. We needed to give it to the patients. The patients had to walk over, have the blood test performed by another person. Those bloods had to be loaded onto a computer and then checked by one of our anaesthetic registrars. Some of our patients lived very far from the hospital, and this meant for them that they were travelling large geographical areas, paying for parking, sometimes taking time off work to have a blood test performed, which potentially we might say was unneeded. And we can't overlook the fact that any blood test really is not a fun event for a patient. So sometimes, this created unnecessary stress, but also we found false positives which then had to be acted on. The Sunshine Coast University Hospital has a big sustainability focus. We're really focused on how we can actually limit the impact of our healthcare, knowing that 7% of the total carbon footprint in Australia comes from healthcare. In 2020, the NHS released this document, which was delivering a net zero health service. And what we learned from this document was that by choosing wisely in this area and really avoiding doing blood tests, that we could actually make big impacts. And this was mostly around medical equipment and also patient travel. The environmental impacts of blood tests were actually analysed in this Medical Journal of Australia article in 2020. And what we learned from this article was that there was very little gain to be made in the way that we perform the blood tests. Recycling wasn't really going to be an area that you could make gains with pathology due to the infection control limits. But this article said the main opportunity for reducing waste and CO2 emissions involves changing the behaviours of clinicians to avoid and reduce unnecessary pathology testing. And we couldn't agree more. Ultimately, over a 12-month period, you could drive a car from where we are in southeast Queensland all the way up to Cooktown based on the CO2 emissions from the blood test done. That doesn't include our group and holds because they weren't analysed through this article. And in the grand scheme of things, I know that sometimes that, it might seem like it's not a huge impact. But remember from what Lana said, that we are really looking at the tip of the iceberg. We're looking at one clinic within one hospital. We're not even looking across our health service, at our emergency department, at our medical admissions. So extrapolating this across all the blood tests in Australia, I think you could drive a car around the world quite a few times. So really the take-home message from Lana and I is that I think if we look around us, that low-value healthcare really is everywhere. In order to make change, it's important, first of all, that you define the problem, and that in creating the change, involving the important stakeholders and working out what's important for all of them, providing ongoing education is really critical. And we learned through our project that ongoing review and flexibility is really critical. And I guess we wanted to show you that a small project can really have a big impact. We want to thank Choosing Wisely for supporting our work. This project has seen us win first prize at our Sunshine Coast Patient Safety Choosy Awards in the poster competition. We've been invited to present at the International Sustainability Conference in Brisbane. We have been chosen to talk about our project through the Choosing Wisely feature story in January this year. We've submitted an abstract to our National Anaesthetic Conference, the ANZCA ASM, and we've just been invited by Monash University to use our findings to develop a short course for healthcare professionals seeking to transition their sector to a more sustainable practice. We hope you've enjoyed our work and feel inspired to audit and look at how your health service can choose wisely and eliminate low-value healthcare. Thank you.
Thank you.
Thanks so much, Lana and Anna. That was a really interesting presentation and some fantastic work you've done there. Well done. So if you do have any questions for Lana and Anna, please do put them in the chat. We have had a few come through, so I'll just read those out now. So Simon says, nice work. A couple of questions from Simon. He missed the start and wondered what the start point for the testing review was.
I'm the clinical lead for our pre-anaesthesia evaluation unit. And Simon, you might not have heard at the beginning that the issue for us within our clinic was that we had kind of surgical protocols for our bloods. We had nurses handing them out, and often they were handed out before the anaesthetist met the patient. So I guess we had lots of people involved. The starting point was really me noticing that we had to check the blood tests, and often I'd be checking blood tests on a patient who maybe had bloods a couple of weeks before that were plumb normal, a patient who was actually fit, healthy and well, having minor surgery. And it became apparent to me that actually the bloods we were doing just could not be evidence-based. And so I guess that was the big stimulus for us to really start looking at it in more detail.
And Simon, I had started this time last year in this hospital, and it was just different to what I'm used to, which is blood tests being done before I requested them as an anaesthetist. So I was trying to figure out why patient X was having a blood test that I couldn't quite figure out when I looked at the IEMR. Why was this patient having blood tests? How was it going to change my management if I was the anaesthetist on the day operating on them? Anesthetizing them. Sorry.
Thanks, guys. Another question from Simon. What is your test ordering workflow?
At the moment, I guess we still have our surgical protocols, which is the protocol that you can see that I actually showed. The nurses actually look at the protocol, so they look at the ASA status and then the surgical complexity, and then they print the format and give it to the patient. The patients then have the bloods done either here within the hospital or sometimes externally. And then the follow-up at the moment is that it's then followed up within the clinic by an anaesthetic registrar. I'm not sure if I've answered your question.
Can I also add that reassuringly, when we looked at, because our graph is obviously based on, our new graph is based on patient complexity. So if we were very reassured that when we, after education with our nurses, that if when they went and decided how complex a patient was, they out of 527 operations, there were only 27 times where there was an ASA discrepancy between either shifting up or down. So they were over 500 times out of 527, they were getting the right ASA, the patient complexity, to the right operation. So they were choosing the right blood test along that graph. Along that graph.
Great, thanks, Lana. And are you using an ERAS approach? I'm assuming that's enhanced recovery after surgery?
Yeah, at the moment we have an ERAS protocol that is for our colorectal surgery. And so that's something that's actually currently under review and audit. It specifically, I guess, looks at a host of blood tests, but then also some kind of anaesthetic implications, I guess, on how we manage that. There is ERAS coming in for other departments within the hospital.
Gynecology.
Yeah, so there are some other protocols. There are a couple of number of different areas that are planning to get ERAS protocols going, but hopefully we can kind of manage to keep the pathology standardised.
Fantastic. And Susan would like to know if the table that was available, is it available as decision support?
Do you mean as in like we spoke to the surgical departments? Is that what you mean? What does that decision support mean?
The table that you presented. I think that's the one she's referring to.
So,
question from Susan, and is that table available as decision support? I'm not sure. The table for indication for blood tests.
As decision support, well, I'm not actually sure what that question means, but basically our plan long term, we haven't managed to roll this out with every department, is that each department has, one of those tables. The nurses in the clinic have access to that. So, yeah, they basically go, what's the ASA status, what's the operation, slide across the table, decide on the bloods, and then it goes from there. And if there's any, questions or or uncertainty, they can discuss with the anaesthetist or the treating team within the department. And our last kind of, safety mechanism that we have in place is that if there is any uncertainty, decision-making or extra bloods that need to be done, is that they can be done on day of surgery as well. So that's the other thing we've put in place.
Mm-hmm. And does that use the EMR?
Yes, so you can actually order the bloods from IMR and have them ready for the patient to arrive on day of surgery.
Susan, if you meant by decision support as in did we speak to the surgical teams involved? Yes, every single protocol has been looked at with the surgeons to make sure that we weren't excluding bloods that they felt were appropriate or necessary.
Which we realised was really important because each department had its own, important things. For example, general surgery, there's been some important stuff that we've had to write into it around thyroidectomies, which I guess isn't relevant to other departments as well.
And just another question from Dan. Did you audit the proportion of blood test results that were signed off prior to surgery?
I'd say
we didn't, not as part of this project. No, we didn't. And that is actually probably a relevant question within our department because the endorsement of results can be very complex. Because the bloods are ordered through our EMR to the surgeon's name, but then the anaesthetist usually endorse them. As a general rule, there's a final check to make sure that they are endorsed, but we didn't actually audit that as part of our audit.
And I just had a couple of questions myself as well. So obviously you engage with smaller departments, but just wondering what the impact was of the project on the wider health service.
So we have been meeting with, as Lana mentioned, we've got a Choosing Wisely, strong Choosing Wisely representative within our department. And that has meant that we've been able to connect with other people. So we have met with the rehab department and we've also met with interventional radiology. And there are a lot of other departments that are also kind of reviewing pathology locally. So it has opened up some of those opportunities for us to, share information and to be able to kind of roll the project out on a bigger level.
Fantastic.
For example, vitamin B12 is being looked at very carefully at the moment, and they've just done a big audit on it. Gen Med's just done a big audit and realised there are repeating blood tests that don't need to be repeated. So it's just interesting.
Yeah, fantastic, great. And just a final question, I guess. If you were going to advise any other health services to implement a similar project, what would be your advice, and what were the key lessons learned that you'd like to pass on?
It takes longer than you think it's going to take. I thought this would be done and dusted quite quickly, but it's like not one step forward, two steps back, but you devise a protocol, then you've got to check with all stakeholders that they're all happy with what we're saying, then you've got to change it, and then then there's like a multitude of emails that go bounce back and forth to try and fine-tune everything. You've got to be a bit flexible because what is intuitive to you isn't intuitive to another person, and things that you want to change. For example, as Anna alluded to, we wanted to do an INR on the day of surgery. What's the point of doing a clotting 3 months back when we saw them in clinic? What is the point of that? We want one on the day of surgery. But a point of care isn't available for us at this moment in time. And it actually requires a training package, for example. So there's loads of little problems that crop up that you have to then address and go back and rechange all your paperwork. But it can be done, and we've been really lucky. Our department has been incredibly supportive and allowing us all this time to get all this project done. And as Anna has told you, we've been very, very fortunate that we have a very strong Choosing Wisely chairperson that looks after us, and we've managed to be involved in lots more things. So,
and I guess the only thing I would add to that is looking at the steps that we presented, I guess, in regards to our kind of project. I think there's power in numbers. I think that if you just went to people and said, I want to change the blood test, they'd be like, whatever. I think coming to them and saying, here's the data, here's the evidence-based guidelines, and this is where we currently sit, and this is the money that can be saved. I think people are really on board with these changes, and we've been, like, each department has been really keen to be involved and really keen to move forward with the changes. And I think that comes, the powers in the numbers. I think you have to have that original audit to prove that change needs to happen as well.
And one further thing, sorry, and we keep on bouncing off each other. We've realized that group and holds, for example, we're doing an unnecessary amount of group and holds for patients that we don't need to do group and holds on, especially when we have Cell Saver here, for example. So now we're looking at an audit at how often are we requiring blood transfusions intraoperatively. So if we don't need to do this group and hold because we're not really transfusing all these patients, then that's another cost-saving initiative that we can start on, and we're auditing that as we speak.
Great. And just one more question from Simon. Was there a discussion about sharing cost savings with individual departments?
I have specifically asked about this in looking, I guess, in if the clinic itself is saving the money, whether or not it can be funded into another way. And I was told specifically no. So I don't think, and I could be wrong on this, but I don't think projects that we have that allow us to save money can actually, you can't actually kind of move that money to another area, unfortunately. So not to my knowledge, Simon.
All right, thank you. So thanks to everyone who submitted the questions and some feedback, some great comments there. Fantastic work, guys. And thank you ever so much for sharing your project and presenting at the webinar. If you missed any part of the webinar today, it will be available online, the Choosing Wisely website, so you can go back and watch any bits that you've missed. And we hope you have a great day and see you all next time.
Thank you. Bye.
Thank you.